wishing you all a very happy new year 2019. I am very much thankful to all the audience who have made my YouTube channel successful. 9.7 million views and more than 24,000 viewers, and lot of mails and a lecture on gallbladder in native language Hindi seen by about 3 lakh people. And I have received so many inquiries and so much input from the general public and the medical fraternity, doctors and medical students who have encouraged me to start this new series of academic lectures. Now the details of these lectures will be based on my experience. I joined Medical College Patiala in 1974. After graduating from there in 1978, I did one rotatory housemanship in Christian Medical College and Hospital, Ludhiana. After that, I did resident housemanship in 6 months in the Department of Medicines and 6 months in the Department of Surgery at Government Medical College, Patiala, followed by a postgraduate course from Government Medical College, Patiala, in which I passed in 1983 January. Since then, I have worked in India and abroad in many teaching institutions and other hospitals, namely Diagnostic Medical College and Hospital, Ludhiana, Christian Medical College and Hospital, Ludhiana, Safdarjung Hospital and University College of Medical Sciences, New Delhi, Sir Gangaram Hospital, New Delhi, and from about 22 years I am doing practice at my own hospital, Dewan Hospital and Advanced Laparoscopic General Surgery Center. During this period, I have come across very large number of patients, and during my teaching career and my learning career, since all the doctors, especially surgeons, have to learn, they have to have a book and they have to have knife. So in that experience which I gathered over thousands and thousands of patients who came to me, and upon majority of whom I operated upon. So based on that experience and my regular reading and search of literature from the net, from the journals and from the books, I will be presenting this academic series. Today's topic is Mirizzi Syndrome. So this is my name and my experience and qualifications and fellowships. I greet you all from Dewan Hospital and Advanced Laparoscopic Surgery Syndrome. Mirizzi Syndrome is today's discussion. These are various pictures of Dewan Hospital. So this again, my YouTube channel. I will request you to subscribe to it, to share it and to benefit from it. Now, what is the importance of Mirizzi Syndrome? Before we start Mirizzi Syndrome, a little word about Dr. Mirizzi. He was basically an Italian who emigrated to Argentina. A very bright surgeon. He traveled all over the world to learn and came back to Argentina again and again, and there he published many papers and he did many new things. The most important thing actually to my mind which he did was a cholangiogram, which was unheard of at that time. And for that, to do a cholangiogram, a just delineation of the biliary tree, he went to Japan to gather the instruments and procedure for that. And he named it Miriziographia Unfortunately, that beautiful invention and the thing which he set into motion did not carry his name. But this Mirizzi syndrome carries his name, although it was before him described by few more surgeons, not completely. So he was not really the first one, but he got the better of that, he got the name Mirizzi syndrome. Now what is Mirizzi syndrome? Say any surgeon, most of the surgeons, 99% of the surgeons, they do operate upon gallbladder. And gallbladder stone, what is the commonest problems of surgical problem and the problems which the surgeons come face to face is gallbladder stones and associated problems. And so I came across gallbladder stone patients and I had to operate upon those patients throughout the world, in the teaching institutions and in the hospitals and in my own hospital, in a very large number. And the presentation varies, has a very large spectrum of presentation. So this gallbladder becomes at times an easy surgery, and you are used to it. Patients come, you follow a protocol, and when you follow a protocol, you investigate the patient and you prepare the patient. After preparing, you get the surgeon to the operation theatre, anesthesia is given, you do the operation and take the post-operative care, patient goes home. So that is a normal routine. This is smooth sailing. Now I am from, like I told you, 1974, 1978 graduated, 1983 I completed my post-graduation masters in surgery. So during that period, the science was like it is always evolving even today. It will keep evolving. Everything, evolution takes place. But during our time, there was no ultrasound. Even ultrasound. What to call of CT scan, MRCP, endoscopy, nothing. And there was no laparoscopy, no that system into place that will make us operate with minimal invasive surgery, have a magnified view, have the privilege and the luxury of all those things which we have today. But during that period also, there were some procedures in place, like oral telepaque tablets and finding out whether the gallbladder is functioning or not functioning. If it is not functioning, it's likely to have that the pain over here is due to the gallbladder. Things like that. And with those things we were managing. Now, in this smooth sailing, sometimes a storm comes, which is not your doing. You don't get the satellite picture always that a storm is coming. The storm may come suddenly. So that thing that we encounter, a rough storm, a period of significant difficulty and dangers. The Mirizzi syndrome is one such sea storm. Caught unaware, it can be unleashing havoc. Unless we meet it head on with our full capabilities, patience and grit. So when the storm comes, your ship, your mind, all things, your danger is in front of you. And you have to be at your best with all your stamina, all your knowledge and all your capacity. So you have to meet it. And because there is danger, here who is there? Who are the two travelers in the ship? One is the patient, another is the surgeon. They are the main ones. Then there is staff and relatives of the patient. So it puts everybody in a grave, dangerous situation. And when the Mirizzi syndrome strikes unaware, you have to be ready for a high incidence of morbidity and a risk of even mortality. That strikes, knocks at your door. The surgeon comes face to face with an already damaged bile duct for which he may be blamed unnecessarily. Now you believe me, since I was student, I was really afraid of Mirizzi syndrome. Oh, this Mirizzi syndrome, I will operate upon a gallbladder and the cystic duct, the biliary duct, the common hepatic duct, common bile duct, the biliary system, especially the common hepatic duct. that will be already be damaged, and I may be blamed that I have damaged it. So such is the problem, like bile duct injuries even at that time were a nightmare, and it was a nightmare for me also. It remains a nightmare for surgeons, especially when it is diagnosed accidentally during the surgery. Now, what is the overview of Mirizzi syndrome? We have discussed, it is a problematic condition to diagnose and treat. Pre-operative diagnosis obtained in 18% to 62% patients only in various studies. Incidence of pre-operative diagnosis improves to 85.9% if we use ERCP and MRCP combined. Advancements in diagnosis have led to a confirmed diagnosis before the surgery. In significant number of cases of Mirizzi syndrome, we can diagnose pre-operatively, actually these days. The second, when we do operation, there is distorted anatomy and dense adhesions because there is severe inflammation and there is dense adhesion. Now, recently, which a case I did, I will show you a picture. There was severe inflammation and dense adhesion. It was like a stone, a frozen Callet's triangle. So in that dissection, there is a risk of injury to the CBD, and you will not find where are the vessels, and if they get injured, there can be copious bleeding. Third, safe and effective surgery can be facilitated by accurate preoperative diagnosis, which is evasive until the case presents as advanced disease. Now, we'll say what's the problem. Now, this we can be safe, make the patient and the surgery safe. But actually the problem is in the initial stages of Mirizzi syndrome, the presentation is just like any other gallbladder stone, acute attack or something like that. All the symptoms and signs are like that unless it is advanced. So there is a problem in pre-operative diagnosis. Fourth, the modality of surgery has to be modified. Now most surgeons, they prefer open cholecystectomy if pre-operative diagnosis is established due to the risk to CBD, and with the laparoscopic approach there is a very high risk of conversion. When the difficulty comes due to Mirizzi syndrome while the laparoscopic surgery is proceeding and difficulty remains there, stays there, as you try to come over the difficulty you cannot come over. After some time, when the things are not clear, one is likely to open, and this is the case with Mirizzi syndrome. Very high incidence of conversion from laparoscopic to open cholecystectomy. Then fifth, the multimodality treatment with additional radiological investigations like MRCP and preoperative endoscopic intervention for diagnosis and therapeutic use. You see, the diagnosis, when there is a doubt, you have to do additional investigations like MRCP, which gives quite good results, and ERCP, endoscopic, visualization of the billiary duct. That gives us a facility to do papillotomy. The opening of that billiary ducts into the duodenum, into the small intestine, that opening, the sphincter can be cut, that the pressure is relieved, and we can introduce a stent inside the ducts. So this is the fifth. And sixth is that in case of Mirizzi syndrome, the normal expenses will not be there. The expenses will go higher. We will have to do extra investigations. Thus, change in surgical procedures, either planned or unplanned. We have to do extra endoscopic interventions, extra stay into the hospital, more medicines, extra risk involved, and these all require that the patient and the family should be taken into confidence. Otherwise, they will say, we had come for a simple gallbladder surgery, sir, doctor, surgeon, sir, and now you are telling us that you need MRCP, ERCP, you have to convert to open. And if the Mirizzi syndrome is advanced and you need further bigger surgeries and you have to stay for a long time, the expenditure increases. So this is the problem of Mirizzi syndrome, and that is why I am taking up this topic today, because it concerns me as a surgeon, and since I am doing a large number of gallbladder surgeries, and I think it will concern all the surgeons, and I think it will concern all the medical fraternity, and it will concern all the patients. So that is why this an overview of the importance, So let me draw for you a simple diagram of Mirizzi syndrome so that we can understand. Now this I will draw a liver. This is diagrammatic diagram, and in this, now this is the right lobe of the liver, and this is the left lobe of the liver. This is the right hepatic and left hepatic biliary duct. They join here to make a common hepatic duct. Now this common hepatic duct, here the cystic duct, which is the gallbladder, that comes, and this goes, this is the sphincter of Oddi, and this will go into the duodenum. So from here the bile is produced and two ducts combine to have a common hepatic duct, and since here the cystic duct is there and this is the gallbladder, which is a reservoir. When we are not eating, the sphincter of Oddi is closed, so the gallbladder is there and the bile is directed, instead of going to the intestine, it goes into the gallbladder and it is concentrated here, and when there is supersaturation, then you say stones are formed here. So for example, a stone is formed here. Now what happens in Mirizzi syndrome? In Mirizzi syndrome, this stone, whether in the Hartmann pouch or in the neck of the gallbladder or in the cystic duct even, this cystic duct can be long or short. Now this presses upon to the common hepatic duct, and since it presses onto the common hepatic duct, so this becomes thin. What Dr. Mirizzi, he named as Miriziographia, was exactly the same thing. You see, the common hepatic duct becomes thin here, and this is a normal caliber CBD, common bile duct, whereas when there is pressure, extrinsic pressure over here, and some stagnation of the bile, these ducts, they dilate. So there is proximal dilatation, then narrowing, and then normal caliber CBD. This is typical of a stone pressing onto the biliary tree, common hepatic duct, and making it narrow here, dilated above, and normal caliber. So I will write here proximal dilatation narrowing common hepatic duct, normal caliber common bile duct, and a stone which can be single or it can be multiple stones, that is pressing onto this. So the definition: An unusual complication of chronic symptomatic biliary calcular disease characterized by partial obstruction of common hepatic duct secondary to benign extrinsic pressure, associated inflammation and fibrosis exerted by a stone or multiple stones impacted in cystic duct, Hartmann's pouch or neck of the gallbladder on to the common hepatic duct, leading to dilatation of the proximal bile system and normal distal bile system. So as I have explained to you, this is the definition. And now this again is the picture which I drew from on my computer, the liver, the proximal dilatation, a stone impacted here and pressing upon into the Hartmann's pouch, neck of the gallbladder, and pressing upon the common hepatic duct. And this normal caliber. And this is the picture of the latest case of Mirizzi syndrome which I have done. You can see that the gallbladder is so much thickened, and this is the lower portion, neck of the gallbladder. And this stone was impacted over here. So the patient went home well, because we could make a preoperative diagnosis and did preoperative preparation. Now, 10 anatomical elements associated with Mirizzi syndrome. Number 1, atrophic gallbladder, which can be thin or thick walled, as you have seen just now, a thick walled one, a very thick wall. Gallstones impacted at infundibulum, Hartmann's pouch or cystic duct. Obliterated cystic duct. The cystic duct, due to stone impacted in it, becomes obliterated. Fibrosis at the Callet's triangle, as you could see the fibrosis there. A long cystic duct with low insertion or a very short cystic duct. External compression of bile ducts leading to partial obstruction of common hepatic duct, as I have explained. Normal caliber distal bile ducts with normal thickening of walls. Now these proximal, not only that they are dilated, there is some inflammation and thickening of the proximal biliary system, whereas this is normal caliber and normal thickness walls of the common bile duct. Dilated proximal bile ducts with thick inflamed walls, anomalous communication between the bile duct and the gallbladder. Now this is the second aspect of the Mirizzi syndrome, that there can be an anomalous communication between the bile duct and the gallbladder, which I will explain now. And anomalous communication between the gallbladder or some other gastrointestinal portion like stomach or colon or small intestine. So I will just make the diagram of this anomalous complication, which is the communication. Like this comes the right duct and the left duct and the common hepatic duct. Now this is the cystic duct and this is the common bile duct. Common bile duct, common hepatic duct, and here is the cystic duct, the duct that combines the gallbladder with what happens here is, this is the gallbladder. You see, this is the gallbladder. To make it more sure, I will make it with the blue. Now this is the gallbladder. Right? In blue. And in green is the bile duct. And here what you find is a communication due to continuous pressure of the stone. Here, stone sitting here has been pressing upon it for a long time, and it can even go inside it. The stone can go even inside it, inside the common hepatic duct. So there is a communication. Now this is that if you take out gallbladder like this, you remove the gallbladder. In surgery what we do is cholecystectomy. Cholecystectomy means remove the gallbladder. And here we remove the gallbladder, and what you find is the gallbladder is gone. but you are left with a hole in the billiary system, which is like a injury to the billiary system. Bile will leak out from here, which is the nightmare of the surgeons. So this is the 10 anatomical elements associated with Mirizzi syndrome. Now what is the incidence of the Mirizzi syndrome? This is very interesting. In the Western world, the incidence is much lower, 0.05% to 2%. Because the gallbladder surgery, the people get the surgery in time. Okay, asymptomatic, no surgery, wait. But as soon as you have real symptoms due to the gallstones, get operated. That's what the surgery is done in time in Western countries, so less. Whereas in other areas of the world, in our country also, the people postpone the surgery. Maybe it will disappear, try some medicines from various types of people, faith healing, from various other pathies. There are many types of pathies in the world, the local pathies and the other international pathies. Or you hope and wait for, so that is what you have the problems that you cannot afford it because many things, whatever the reason, the things get delayed. And the incidence of Mirizzi syndrome increases from 4.5 to 6%. Right? So that is very important factor which leads to this complication. Now, presentation. How does it present? What are the symptoms and signs? It can be asymptomatic. Just that you can't find any symptom if a patient has it. Or if there are symptoms, they are non-specific symptoms. Like any other symptoms of gallstones or even abdominal pain due to other reasons. So symptoms, nothing specific to it. But it can have some mild jaundice depending upon the obstruction, or it may not have. There can be elevated liver enzymes, or rarely if the stone which comes here, like stone from here, sometimes the fistula of the gallbladder, this forms with the stomach, say any intestine. Instead of the fistula forming here, this is the cystic duct and this is the CBD. The fistula forms with intestine and stone goes into the small intestine and gets stuck in the small intestine. And the patient comes with intestinal obstruction. So which is rare, not common. So these symptoms, I will say that there is really no very specific symptom of Mirizzi syndrome. And even sometimes we can have a false Mirizzi syndrome due to something else. Like again, there can be acute cholecystitis. In acute cholecystitis, you can have a gallbladder here, a gallbladder which is very much dilated and inflamed. Acalculous cholecystitis, maybe due to salmonella infection, and it presses upon to this. And you can have something like a Mirizzi syndrome. Residual stone, after the surgery has been done, a small stone is stuck over here in the cystic duct. This can again create a situation like Mirizzi syndrome. Malignancy of the gallbladder or the biliary duct adjoining portions, anywhere the malignancy here in this area, whether primary or secondary into the lymph nodes over here, draining area, the bile comes from the lymph comes from the small intestine, large intestine, the metastasis over here, or the malignancy. So this will present as if it is a stone or malignancy. We have to remain alert. Now what is the classification of Mirizzi syndrome? McSherry et al. Divided into two types. Impacted stone causing the slight external compression of the bile duct, that is about 50%, 10 to 15%. Type 2, like we had discussed, that the stone that erodes into the bile duct. He did only two things: whether the stone has eroded inside into the bile duct, common hepatic duct or not. If there is a communication between the gallbladder and the CHD stage type 2, if there is not, just pressure onto it, type 1. Now this was modified by Sanders into further types. The type 2 is that he did type 2 divided type 2 into 3 types. Type 1 remains the same, that is that there is a stone over here which is pressing upon this and causing this compression, right? Now stage type 2 is that there is a communication between the gallbladder and the biliary ducts. Now this is that 2, 3, 4. If this is 1/3 area of the bile duct, common hepatic duct, has been eroded and destroyed in the circumference, this is the circumference, divide it into 3 portions. If 1/3 has been, less than 1/3 has been taken place, that means stage 2. If 2/3 has been taken place, erosion has taken place, and this the stone has destroyed all this, stage 3, 1/3 to 2/3. And if more than 2/3, that means complete destruction. That means this area is gone. What is left? Hardly anything is left. This all is stone. And this, only this much bile duct is left. So more than 2/3 is erosion of and destruction of the circumference of the bile duct is type 2, 3 and 4. Mattern et al., he said type further 5, that like I described, that instead of the biliary fistula is between the gallbladder and the bile ducts, that is between the bile ducts and there is a in the intestine, and in that again type A and B, whether the stone has gone away and not causing any intestinal obstruction, 5A. It is causing obstruction, 5B. So this is the there are many other classifications, but I usually follow these classifications. Now what is the role of imaging techniques? Like I told you that in 70s and early 80s we didn't even have ultrasound. Now we have many imaging techniques, and what is the role of those imaging techniques in Mirizzi syndrome? Abdominal ultrasound. It is easy investigation, it is cheap, it is non-invasive. And for any pain abdomen, this is the first investigation. So here the diagnostic accuracy is less, only 8 to 30%. This, if the person who is ultrasonologist is good and spends time, he can pick up dilated proximal bile ducts and distal ones are narrow. And this can put a suspicion onto something pressing upon to the biliary tree, which is causing proximal dilatation and normal below. So this we cannot ignore. That is important, that such things, a small indication should not be ignored. CT scan. This is not very specific, but it is good to differentiate between Mirizzi syndrome due to stones and carcinoma, and for staging of carcinoma. So it can help us to avoid pseudo-Mirizzi syndrome. And if there is carcinoma, so depending upon the diagnosis of carcinoma and its staging, MRCP is preferred investigation. it is say quite up to say 90% cases we can make a diagnosis, and it can delineate the typical characteristics of Mirizzi. That is extrinsic compression of common hepatic duct, dilatation of common hepatic duct with normal cantilever common bile duct, and stone in common hepatic duct in case it has eroded inside the common hepatic duct. MRCP is the only real investigation, magnetic resonance cholangiography. So this will give us a very good picture of the biliary tree and even stone eroding into it. ERCP is an invasive investigation, but in this case it gives us a very good diagnosis. It's a gold standard diagnosis in this case because we get a cholangiogram. The whole of the bile tree is seen with the radiopaque dye and x-rays taken or on the screen. And not only that, it provides us a diagnosis, it helps us in therapeutic. We can decrease, we can, I'll just draw it again. Now here the lower portion, these are the right and left and the common hepatic. Here everything in Mirizzi is going on, and here we are coming with the sphincter of Oddi, and here is the duodenum. Now our scope has gone here. So when our scope reaches here, and with this we cut open this sphincter of Oddi, papillotomy. This papilla of Vater is cut open. Sphincter is gone, so the pressure is relieved. The chances of leakage is decreased. And second thing is that we can introduce a stent here which helps in surgery in decompressing the biliary system. And if we put a biliary nasal system, then we can even inject dye during the surgery through a biliary nasal tube, and the dye can go into and we can have a cholangiogram right at the time of surgery to see whether we are safe, the CBD and the biliary system is safe. Now this can help us intraoperative cholangiogram. If it is not put, then nasobiliary drainage tube, then we can do the intraoperative cholangiogram. Now if there is a leakage of bile from bile ducts after removal of the impacted stone, and we are not sure that maybe the damage is small, and we suspect the bile is not coming but the necrosis is there, so intraoperative cholangiogram can show us whether there is any leakage, or if there is a fistula, the dimensions of fistula. Now other things which are not always available and people are not routinely using is the intraductal ultrasonography, or endoscopic ultrasound can also be used. Now the role of ERCP which we are discussing in Mirizzi syndrome, well, it is a gold standard diagnostic tool which gives us a diagnosis in 80% to 100% of cases. It provides therapeutic decompression by papillotomy and stent or nasal bile drainage. Nasal bile drainage helps to decompress biliary ducts during surgery and to perform intraoperative cholangiogram. It can, the main help is that if there is a fistula, we can avoid putting a T-tube. So we can keep this, it's simple. It delineates very well the obstruction, dilatation of the bile ducts and the presence and location of polycystoduodenal fistula. Stones in the bile duct. Now there can be other stones in the bile ducts. They can be also removed. Or that stone which is impacted in the bile duct, which is come from here, from the gallbladder, and it's gone inside the bile duct. That stone may also be removed. But when during ERCP, we are not able to remove this stone, then we should also think that there is a Mirizzi syndrome. That stone is not only in the lumen of the duct, but is stuck inside the gallbladder. Now this gives a suspicion for the diagnosis of Mirizzi syndrome? Well, there is various types of the stone is difficult to remove the basket. One can do it with electrohydraulic lithotripsy, mechanical lithotripsy, chemical dissolution or laser lithotripsy. The latest being spy glass technique. Now this spy glass technique is the latest technique through which we can remove very difficult stones of Mirizzi syndrome stuck inside the gallbladder, and as the name implies, spy glass technique. Right. So ERCP can provide intraoperative cholecystoscopy. Well, you can have a small cholecystoscope and you can introduce the cholecystoscope inside the billiary system. It is an invasive procedure and ERCP has its own complications. It can cause bleeding, it can even cause pancreatitis or cholangitis and similar other problems. So it carries its own problems. Surgery for Mirizzi syndrome. After all, our endeavor is to operate upon the patient of gallbladder stone, and if the patient has Mirizzi, then we have to still operate upon the patient. Now, problem is that what are the challenges in this surgery? Now, because there is a very low incidence of suspicion and the presentation is non-specific, we, the surgeons, often are not able to detect the condition periodically and get caught as an emergency, unprepared. The patient is unprepared and the surgeon is unprepared. Either you can say both ways, surgical technique wise and mental preparation is not there. So, second, distortion of anatomy. By dense adhesions and presence of choledochobiliary indirect fistula increases the risk of bile duct injuries and chances of massive bleeding due to the dissection of frozen callus triangle. Now, believe me, this picture which I had shown you, this Mirizzi syndrome I had come to know preoperatively, and I did MRCP and ERCP. Stenting was there. I proceeded with the open cholecystectomy, and I followed special technique of open cholecystectomy which I will explain later. But even then, close to the callus triangle, it was like a stone. I couldn't dissect it away easily, even the gallbladder. So, very difficult dissection due to long standing fibrosis. It becomes like a stone. You cannot delineate various structures, and you cannot use your sharp instruments, and you cannot be fast. There is a high risk of biliary cutaneous fistula, like the leakage of the bile later on, and a biliary stricture. Not only that, later on the bile duct which is damaged may shrink and become stricture. This will obstruct the passage of bile, and the bile will go into the blood. Not the topic of my discussion today, but it will lead to obstructive jaundice. And this obstructive jaundice, which can be surgical or caused by the stone, the Mirizzi syndrome, the sequelae of Mirizzi syndrome, will lead to secondary biliary cirrhosis, which is again a very dangerous problem, a very chronic and long-standing, difficult problem, and at times mortality. That person may die. So these are the challenges of Mirizzi syndrome. Now, what are the important strategies to meet this syndrome? For anything in life, one has to have a strategy. Now we know the problem, that we may know the problem beforehand, or we may not know the problem beforehand. In all conditions, we are the one and the patient is the one who have to face this problem. And we have to have a strategy to meet the problem. Well, it is a formidable challenge and a test to surgeons' ability and dexterity. Now, we have to dissect the gallbladder close to the liver margin. right? Fundus first approach, yes. The problem mainly lies below. So, when the problem mainly lies below, the problem is here. Stone is stuck here. So what we do is start from the area above, fundus. Fundus first. We start doing surgery from above and go down. Then which we follow is that open the gallbladder. We mobilize the gallbladder and then we open the gallbladder. Make a hole into the gallbladder, and from that gallbladder you see, remove the stones, stone, remove it out. Now this you can extend the gallbladder now. As you extend the gallbladder, you can identify the structures from below, inside, like the cystic duct opening. It may be obstructed or may not be obstructed, but you can identify from within, because outside there is deep fibrosis and you are in danger. So we identify the neck early, open the gallbladder, remove the stones, start from above, and careful, appropriate dissection, slow dissection. No quick scissors and all if you are doing open, or even laparoscopic in a case. Slow, easy, with patience, looking on to what you are doing. Then we have the Rowe's sulcus over here, which gives us the plane where the this biliary system goes inside into the liver, right? And the portal vein comes outside. The hepatic artery, portal, that sulcus you can see, and as a landmark plane of CVD and common hepatic duct. So you can have an idea that where you are. Remain constantly alert and aware about the position of common hepatic duct and common bile duct. Laparoscopic approach to Mirizzi syndrome. Everybody wants surgery with minimal invasive, less cutting, less incision, short incision. That is what buttonhole surgery. It has become popular. People have taken it. Surgeons have taken it. They still want it. What can we do it in Mirizzi syndrome? That is the question. Well, if you do it, there is a high conversion rate, 11 to 80%. You can take the patient in confidence and you can try it in type 1 cases only. Like if we go back to the type 1 cases, like type 1, impacted stone with causing slight external compression, no fistula, only in that cases, right? So, well, there is increased risk of bile duct injuries due to severe inflammation and fibrosis and anatomical distortion, because fibrosis, it shrinks and pulls the structures this way and that way. So anatomy is distorted. You still have to do a fundus first approach, starting from above, as I have drawn that this is the gallbladder and this is the fundus of the gallbladder. Start from above. Extracting stones and then making this helps in identification of the neck of the cystic duct. Now another thing is, which of course one has to follow sometimes, not that one should follow or not follow, is a partial or subtotal cholecystectomy. Normally what we do is, this is the cystic duct and this is the gallbladder. We remove the gallbladder right close to the biliary duct, common bile duct, not very close, but close to the identifying everything. Now here is a partial, means that you have this portion and you have started from the fundus, you have opened it, removed the stones, and you are dissecting. Well, you find here it is gone very tough. It's not that when the things get tough, the tough get going. It's not like that. When the things get tough get going. Here you make a compromise. Then don't go up to him, just stop him. I have done it myself many times. This neck of the gallbladder, just ligature. Laparoscopically, put a ligature. Clips won't work, but the thick and dilated. The stone has come out, or otherwise you put a ligature and leave a stump here. Of course, make sure that the stones are out. This is partial. Now what is again a new system, especially with laparoscopic system, but you can again apply it for open technique. That is that this is the gallbladder. I'm making it bigger. And here what is done is that start from the fundus, as much is mobilize. When it gets a bit more tough, just cut it from the wall close to the liver and just cut the walls here. Leave this portion into the liver bed. This is the liver bed. And leave this portion as much as getting stuck here, leave this portion. And keep cutting here. This will keep opening the gallbladder as much as possible. And if it is, for example, cut up to here or here, wherever, or here, you have a chance, you will have this lumen type of thing, which will be like this. So this portion, a tube here, and which will be the portion here, this will be the portion here. This wall we will be leaving, like we do in cirrhotic patients, to avoid bleeding from the gallbladder bed. Many times we leave the posterior wall close to the liver to avoid bleeding. Otherwise, even I had faced 2 torrential bleedings in cirrhotic patients. So then I started following this strategy of leaving the serosal wall of the gallbladder in severely cirrhotic patients stuck to the liver bed. So you can leave it over here. This is the liver, leave it over here. Here you put the sutures, whether it is open or it is laparoscopic. You can put a bursting suture. And bursting suture, when you tighten it, becomes tightened. The things close from inside. Because again, it may be very difficult for you to go into this area. In case you go, then you can do a partial cholecystectomy, just tie it over here. But cannot do the subtotal, you close it from inside, the bursting suture. Now this thing is at times saves the day for the patient and for the surgeon. And this risk of some mucosa living here is very little, which can secrete later on secretion. You can cauterize it, and it will be, mucosa will be destroyed. There will not be any mucus secretion and anything. Now this partial cholecystectomy, to leave the cystic duct and a part of the infundibulum, as I told you, extract the stones close to the communication by bursting sutures from inside the infundibulum. Now this is in those places where there is no fistula. Now in those patients where there is fistula, and you see then what to do. So here in type 2 and types of type 2, 2, 3, 4. Now 4 we will come later. In say type 2, 3, I will get back to that slide. Yeah. In type 2, 1/3 of the circumference of bile duct is gone, right? 55% of Mirizzi syndrome. And type 3, up to 2/3. Type 4, more than 2/3. Now what is it implies over here is that this here, this gallbladder, this 1/3 of this bile duct portion, Mercedes sign, so 1/3 is gone. And this 1/3 is gone, when you take it out the gallbladder, it will go. So there can be a strategy for this. That is cholecystoplasty. What is cholecystoplasty? Now you have this tissue over here. You remove the gallbladder, and for example, actually I made the fistula bit above. So if this is the gallbladder, because the stone is usually stuck below, right? So when we remove the gallbladder like this, and we do all these things, closing and all, now this portion of the gallbladder can be taken over here like a skin graft type of thing, and we can stitch it over here. Some part of the gallbladder is stitched to the closure of that opening, and it works well, although it is inflamed and fibrotic. In case there is a small opening and you can lay your hand onto this, this works well. If you have a billiary system, very fine. If there is a stent, you can put a drain, or otherwise you can put a T-tube drainage to decompress, just a T-tube drainage, right? So this thing helps. Now if this is more than that, then it will not help. So gallbladder is open right at the fundus, stones, and free portion of the gallbladder is removed, leaving the wall of the gallbladder to the gallbladder bed. Cystic duct neck of the gallbladder is identified and closed from inside like a pulsing suture. Now these procedures are again followed in laparoscopic procedure. So we will go ahead now. Now what is Roux-en-Y hepatojejunostomy? Now when the situation, I will come back to this. When this duct, not 1/3, but close to 2/3 is damaged, what can you repair it by any plastic or anything? It is just half, less than that even. This much, or this much. No. Then we have to have a bypass procedure. That is Roux-en-Y bypass procedure, in which I'm not discussing it, Roux-en-Y procedure, in which we drain the thing into the bile, into small intestine. We take a portion of the small intestine. Now this is the small intestine. Now this is the bile duct, which is badly damaged. So this is the small intestine. We cut the small intestine over here, and we take one portion of this thing, we bend it like this, and we attach it over here. So the bile goes to small intestine. The continuity of the small intestine is maintained by end to side suture over here. So this intestine continues like this. One portion of the intestine drains the bile. This is basically Roux-en-Y, which we will discuss in another lecture. And this should be done when the damage is more. So surgery in Mirizzi syndrome as per type of disease. Type 1 and 2 ERCP with papillotomy and stent nasobiliary tube, followed by open partial subtotal or closure of the tract of bile duct without gallbladder tissue, as I had explained to you, and placement of T-tube in the CBD to decompress the common bile duct. Type 4 procedure of the choice is Roux-en-Y hepatic osteogeneostomy as we have discussed. Now, association of carcinoma gallbladder with Mirizzi syndrome. So, this chronic problem which leads to Mirizzi syndrome, it is less in Western countries and more in the other countries where the cases are delayed. So, large stone which is single stone present in the gallbladder is associated with high incidence of malignancy as such and is associated with Mirizzi syndrome. The genesis of both type of conditions is similar. So there is likelihood of carcinoma with or without Mirizzi syndrome and we have to be aware of it. And the incidence is 6% to 28% and mainly in type 2 and higher types. So in case this is a carcinoma, CA99 is markedly increased more than 800 units per milliliter. CT scan, MRCP can help. At the time of surgery, you can take a frozen section and see, because then you can plan that radical cholecystectomy with hepatic vein resection and lymph node dissection, so that the surgery is completed and proper staging is done for further management of the cancer. A robot-assisted technique for Mirizzi syndrome can provide enhanced visualization with 3-dimensional camera, and surgeon can perform professional fine tissue manipulation with endo-wrist instrument. The robot can bend the wrist more like that. We cannot bend. So a robot has its own benefits, and its availability and training and other things are a different topic. So most significant message. Now what is the message, most significant message for Mirizzi syndrome? That is, should not be taken lightly. Don't underestimate it. When you find on ultrasound that the proximal ducts are dilated and distal are normal, there is stone stuck, and there is slight jaundice, slight raise of the enzymes, you think, okay, no problem, there is an old ultrasound few months back, and you don't repeat the ultrasound. There lies the problem, there lies the pitfall. Don't underestimate it. The recommendations for Mirizzi syndrome. For cases suspected to be suffering from Mirizzi syndrome, on ultrasound examination, should be a mandatory system to do MRCP, CT and ERCP. You must consider it. For cases of Mirizzi syndrome found incidentally during the surgery, careful dissection, minimal traction on the fundus first dissection, extraction of stones to make the anatomy clear from inside the gallbladder, subtotal or partial cholecystectomy, and documentation by taking pictures or video recording. Mind it, nobody is 100% sure that everything will go all right. That you may be blamed that the CBD injury, you are saying Mirizzi syndrome, Mirizzi syndrome, Mirizzi syndrome. Actually, you have damaged the CBD and you're taking the name of CBD. So, what is the problems you are facing? Start documenting it. Get a digital camera, a video camera, take pictures. Even in the open case, laparoscopy case, do the recordings. That is help you to document the thing. So mandatory conversion to open even by a senior and experienced surgeon if the pathology is found advanced and anatomy is not clear. There should be no room for ego. There should be no place for ego, because we are the surgeons and doctors. We have white coats to wear and they get spotted. So we will be blamed. It can lead to medico-legal complications. It can go to court. It can go for settlement. It can put the patient, family of the patient, the surgeon and the hospital into great strain. To avoid all these things, have an attitude of no compromise. If you have the slightest suspicion, follow the protocol. you must do further investigations, and if you find on investigation Mirizzi syndrome, you must change the plans and must take into confidence the patients and the family for all the extra investigations, change in the surgical technique, and extra stay in the hospital, extra risk. And this alone will give us a good outcome, a happy outcome, and will keep the patient and the surgeon sane in a safe condition. So with that, I thank you everyone for listening. Those who will listen, I thank you them. Thank you very much. And I dedicate this presentation to the sweet memory of my parents. My father, he was an advocate